Hi everyone, welcome to this session on haematology. So if you look on the top right hand side of the slide, that's the link to our Instagram page. So please follow us and then you'll get all the links for our sessions that are coming up. And then on the bottom left is our email address. So feel free to email any questions about the session today or any questions about any of our sessions. Drop us an email and we'll try and get back to you as soon as we can. So here is the link to the polls for today. So I'll give you a minute just to get logged in. I'll post it in the chat as well quickly, just so if anyone joins late, then they can also join in. All right, hopefully that's enough time for you guys, but it's in the chat if you need it. So my name's Anea. I'm an F2 doctor at Frimley. I'm one of the kind of founders of the Med Crash course series as well. Today we're going to be talking about hemolytic anemias, and included in that, I'm going to talk about hemoglobinopathies and also a little bit on transfusion reactions. So hemolytic anemias occur when you get peripheral destruction of red blood cells, which means that the red blood cell lifespan is massively reduced. So does anyone know what the normal red blood cell lifespan is, or just have a guess if roughly what you think it is? You can type in the chat or unmute. Happy either way. Even if you don't know, have a random guess. Give you 10 more seconds. Cool. I'm going to take that to mean no one has any idea. Oh, someone's typing. Oh, fine. I was asking, does anyone know how long red blood cell lifespan normally is? Yeah, perfect. 120 days. So in hemolytic anemias, that's reduced. And what happens is that the bone marrow continues to produce red blood cells, but there's a problem either with the environment or with the cell itself. That means that the cells are broken down more quickly, and the bone marrow works harder to try and compensate for the reduction, but the production is still less than the destruction, and that's what leads to an anemia. So throughout today, I think some of the things we talk about are probably a bit beyond the level that you need. And I didn't want to panic anyone because I know you guys are probably coming up to exams, and I remember that feeling of being in lectures when things were above what you knew and getting really panicked. So if there are slides with Kevin's face on, panicking, it means don't worry about it. Probably isn't going to come up. I'm just including it for completeness, but just don't panic. So that's on some of the slides, and that's why. So this is what we're going to go through today, which probably looks a bit scary to begin with, but we're going to break it down bit by bit, and hopefully it won't be so bad. So first thing to break hemolytic anemias down into is whether they are inherited or acquired. So we're going to start with the inherited causes. So within the inherited causes, you've got your hemoglobinopathies. So we're going to talk a bit about sickle cell and thalassemia. Then you've got your membrane disorders. So we're going to talk about hereditary spherocytosis. And then the third inherited cause to know about is G6PD deficiency. So we're going to start by chatting a bit about hemoglobin. So there are roughly 250 million hemoglobin molecules in every single red blood cell, which means that just one red blood cell can carry up to 1 billion oxygen molecules. And I don't know if it was just me, but I always used to imagine like each red blood cell in that little dip had one oxygen molecule, but that's absolutely not how it is at all. So anyone else who has that image in your head, get rid of it. And there are a couple of different types of hemoglobin to be aware of. So there's HbA, which is what we call our adult hemoglobin, and that's what makes up 95 to 98% of hemoglobin in the majority of adults. And that has 2 alpha chains and 2 beta chains. And then you've got your fetal hemoglobin, which in adults you still have a little bit of. You have about 2 to 4%, and that's made up of 2 alpha chains and 2 gamma chains. And then you have your HbA2, which is your kind of second form of adult hemoglobin, which makes up a small percentage. And in that you have 2 alpha chains and 2 delta chains. So moving on to sickle cell. So sickle cell happens because of a point mutation in the beta globin gene, which is located on chromosome 11. And what that mutation does is it causes an amino acid substitution. So a glutamic acid on the globin chain is swapped for a valine, which seems like a very small issue. But what that means is that this new HbS, we call it, so in this new type of hemoglobin, when it's deoxygenated, it polymerizes much more quickly. And that's because usually when it's oxygenated, that new valine group is tucked inside the molecule. But when it's deoxygenated, the form of the HB changes a little bit, and that valine is then sticking out. And so that means when it's deoxygenated, that valine interacts with other kind of parts of other HB molecules and causes them to stick together. So that means inside of the red blood cell, you've got all these long chains of HbS, which make the red blood cell change shape. So it goes from its nice, squishy, kind of curvy shape to being sickled, which you can see what it looks like up there. I'm sure you probably already know what it looks like, but that's what causes it to look that weird shape. And to some extent, when it's oxygenated, it can kind of flip back to being its normal shape, but it still just causes a lot of damage to the red blood cell wall and makes it a lot stickier, and it can't, when it's in its sickled shape, it can't really flow past the other red blood cells as well. So that leads to this vaso-occlusive phenomena. So it means that the sickle cells kind of clump together, and also hemolysis. So the red blood cell lifespan goes down from 120 days of the normal red blood cell down to just 17 days. So it's a massive difference. And all the symptoms of sickle cell arise from either the vaso-occlusive phenomena or the hemolysis. So there are a couple of different conditions you should know about that cause sickling to occur. So the first one is if it's cold. Second one is hypoxia. Third one is dehydration. Fourth is acidosis, and the fifth is infection. So I think bear them in mind because they're important just to remember. And there are lots of different complications of sickle cell. So sickle cell patients are way more likely to have strokes. At least 50% of sickle cell patients are going to have at least one episode of an acute chest crisis in their lifetime, which is when you get clots in the chest, sometimes and sometimes not associated with infection. The spleen is obviously working really hard to try and clear all these red blood cells, so you can get splenomegaly, lots of other different things. Priapism's common as well, bone marrow infarction and osteomyelitis, so lots of different things, and chronic pain is also a big one. So first SBA, a 33-year-old gentleman with known sickle cell comes in complaining of severe pain in his chest. He is tachycardic and febrile. His SATs are 92% on air. How would you manage this gentleman initially? Let me just open the poll. There, poll should be open now. So A, are you going to give oxygen, analgesia, IV fluids, consider some antibiotics? B, are you going to refer to haematology immediately? Are you going to hold off analgesics initially and discuss with his haematology team? Are you going to give him an immediate exchange transfusion, or are you going to encourage oral hydration, get a chest x-ray and discuss with the haematology team? Fab. I think you're both pretty speedy on that one, so I'll stop the poll. And you're right. So you're going to give oxygen, analgesia, IV fluids, and consider antibiotics. And then obviously you would want haematology team input, but a bit later after you've done the initial stuff. It's a bit of a kind of a controversial thing in sickle cell. A lot of people are reluctant to give analgesics, and there's been a big push to try and move away from that, and they're in a lot of pain, so just give them analgesics. There's this kind of weird thing about sickle cell patients and people being reluctant to give them pain relief, but just give it. And exchange transfusions might be needed a bit down the line, or just normal blood transfusions just to get their percentage of the HbS down, but that's probably after giving them good hydration. So sickle cell management, patient education is really important. Obviously they're going to live with sickle cell for their whole lives, so they really need to be aware of what causes sickle crises and how to avoid them. General care, so they can have folate supplements, need to be up to date on their immunizations, can give antibiotic prophylaxis as well. And you need to manage the acute complications, so analgesia fluids, exchange transfusions. To try and prevent the vaso-occlusive phenomena, so some sickle cell patients do just have regular top-up transfusions or exchange transfusions. And there's also a medication called hydroxycarbamide, which is the same thing as hydroxyurea. And that stimulates the bone marrow to produce more fetal hemoglobin, and that way it reduces the level of sickled hemoglobin. In terms of chronic complications, so they can become high in iron, especially if they're getting transfusions regularly, so they might need to be on iron chelators to try and bring that down. And there are some kind of rare curative treatments out there, so stem cell transplants are kind of becoming a thing, but aren't really a main treatment yet, but hopefully in the future we'll get there. So thalassemia is the second hemoglobinopathy to know about. So in thalassemia, you get a severe reduction or absent production of either the beta or the alpha globin chains. It's a bit more complicated in terms of the genetics of it than sickle cell. So there are kind of lots of different mutations that can cause varying different severities of the illness. The main one that I think to know about is beta thalassemia major, and that's the one that med school questions tend to focus on. That's the one I'm going to go through. So in beta thalassemia major, you get a problem with chromosome 11, and that results in there being no production of beta globin at all. So they have slightly raised HbA2 and HbF to compensate for this. It presents in childhood with hepatosplenomegaly, microcytic anemia, and usually faltering growth as well. And we also screen for it now in at-risk groups. It's much more common in Indians, in Mediterranean people, and in people from the Middle East. And you end up with this kind of chronic hemolytic anemia and the body struggling to make red blood cells. And because the bone marrow is working hard, you end up with it trying to create blood in places where it wouldn't normally create blood, which is why you get kind of skull bossing and maxillary overgrowth as well sometimes. This is much less commonly seen now because we identify it quite early and give lifelong transfusions, so the bone marrow isn't working so hard to make blood because they're not as anemic. But they'll need lifelong transfusions, and the problem with that is that it often causes iron overload, and so people with thalassemia often have problems with high iron, and they have to be on regular iron chelators. But that's the main in nowadays, that's kind of the main problem with thalassemia now. And again, there are stem cell kind of therapies that are starting to come in, but they're still not mainstream and still quite a risky option. So next, SBA. So you're in the lab looking at a blood film for one of your patients who you suspect may have hereditary spherocytosis. Which of the following blood films would be most consistent with hereditary spherocytosis? The A, B, or C? Polls open now. This is a bit of a tricky question. Right, you have both had a go, so we will move on. So the answer is C. So if you look at the blood film of C, you can see these very round red blood cells that have no central pallor either, and they're what we call spherocytes. So that's what you see in hereditary spherocytosis. The first one, A, we're going to talk through a bit later, but that's what you see in a MAHA. And those little things that look like croissants are called schistocytes, and they're kind of breakdown of red blood cells, but we're going to talk through that later. And the second one is what you see in G6PD. So the one with the arrows pointing to, that's a bite cell. And I can't see any Heinz bodies on this one, but I'll show you them a bit later. But the answer for hereditary spherocytosis is C. So in hereditary spherocytosis, like we've just said, instead of having these normal biconcave, like disc-shaped red blood cells, you get these spherical shaped cells. And it's caused by mutation in one of the genes that codes for the structural membrane proteins. So basically there's a problem with the red blood cell membranes, and that's what causes the shape to be different. And it's usually autosomal dominant in its genetics. So in terms of presentation, they're going to present with splenomegaly. A lot of these patients as well need splenectomies because their spleens get so big. Failure to thrive, jaundice as well occurs because of the hemolysis. So jaundice is very common in all the hemolytic anemias, and gallstones as well. So on the blood film, you see these spherocytes that we've just talked through, and the cells just generally are more fragile as well. So they break down a lot more easily because of the problem with the membrane. So third one is G6PD deficiency. So G6PD is an enzyme that helps the red blood cells to work, and it protects them from substances in the blood that can harm the red blood cells. And without G6PD, the cells just lyse really easily. So that's what causes the hemolysis in G6PD. So it's an X-linked condition, which means it's a lot more common in males. It does occur in females, but a lot more rarely because girls have 2 X chromosomes, so they can kind of compensate for it a bit better. And it's more common in African heritage. On the blood film, you're going to see these bite and blister cells. So the Heinz bodies are those little dots on the outside of the red blood cells, and the dots are denatured HB particles, and bite cells are when they get to the spleen. Sometimes macrophages in the spleen just bite off those Heinz bodies, and then you get what are bite cells. In exam questions, they like to mention fava beans and how fava beans can make it worse, and they also like mentioning dark tea-coloured urine, which is one of the symptoms. So next, SBA, which drugs trigger hemolysis in G6PD? I put Kevin in the corner because I think this is a bit of a mean question, but it's one that's worth knowing. I think it's unlikely to come up, but worth knowing anyway. So have a guess if you don't know. Fab. So answer is the sulf drugs. So things like sulfonamides, sulfasalazine, sulfonylureas as well can trigger hemolysis. I don't know the background behind it, but it's just one to be aware of. This is a nice table off PassMed that just compares G6PD to hereditary spherocytosis, because I know they can seem quite similar. But yeah, if you remember, G6PD is more common in males, whereas hereditary spherocytosis is kind of more split evenly. And another big difference is where the hemolysis occurs. So in G6PD, the hemolysis is occurring in the peripheral blood, whereas in hereditary spherocytosis, it's more in the spleen, and the spleen's just noticing the cells look a bit weird and getting rid of them. Fab. So that is all of our inherited hemolytic anemias that we've gone through. And now we're going to move on to the other side. So we're going to start going through the acquired causes. So the first acquired cause is when you have a problem with the red blood cell, but it's not immune, which is something called paroxysmal nocturnal hemoglobinuria. This is one that I put Kevin on because I very highly doubt this will come up in exams, but just for completeness, I'll quickly run through it. So PNH is very rare, and it's caused by a mutation in the PIG-A gene, or defect in the PIG-A gene, which leads to a lack of these proteins on the surface of the red blood cell. And one of those proteins that ends up not being there is one that protects against this membrane attack complex. So if you don't have this membrane on the surface of your cells, then your cells get broken down very easily. And it can sometimes occur after an aplastic anemia. And it's called PNH, just a fun fact, because patients often get blood or very dark colour to their urine, either at night or earlier in the morning, but not so much during the day. So that's that one. Don't worry about it too much. And now we're going to move on to the next one, which is when you have a problem with the environment and it's not an immune cause. So this leads us on to our MAHAs, which you've probably heard of. And MAHAs stand for Microangiopathic Hemolysis, and it's when you get a mechanical destruction of the red blood cells in the vessels. And you see what we call schistocytes, which are fragments of red blood cells on the blood film. And I think they look like croissants, and that's how I remember it. But take your own, whatever you think. I think they look like croissants. And there are 4 MAHAs that you need to know for finals. There are a lot more of them, but I think these 4 are probably the big ones. Even this, I think you need to know them. I think they're the top end of probably what you need to know for hemolytic anemias. But the first one is TTP. So TTP is fatal if you don't treat it. It's often idiopathic, but can be due to drugs, pregnancy, sometimes HIV. And what happens is you get endothelial damage, and then von Willebrand factor is released. Von Willebrand factor binds to receptors on the platelets, and it causes the platelets to aggregate. And when you get platelet aggregation, it causes more kind of shearing and breakdown of the red blood cells because of the turbulent flow through the vessels. And it's caused by a deficiency in this von Willebrand factor cleaving enzyme, which is Adams TS13, which means that there's even more platelets. So you don't have this enzyme that breaks down the von Willebrand factor, so you have even more von Willebrand factor, so even more platelet aggregation. So I hope that makes sense. And you need to remember, main thing to remember is this pentad. So if you see it's a hemolytic anemia, and then in the question stem it mentions fever, renal failure, confusion, thrombocytopenia, and there's a MAHA on the blood film, so you can see those schistocytes, then that's when you should start thinking about TTP. So, that being said, which of these is not part of the pentad in TTP? Oh, I need to give you the answers, don't I? Is it going to make it go to the next slide? There we go. So A, fever, B, renal failure, C, confusion, D, hypoxia, or E, MAHA on blood film. Give you 5 more seconds. You guys are very quick at answering today. I like it. Fab. Yeah, you are both correct. Answer is hypoxia. Oh, one a bit weird. Okay. Yeah, so hypoxia is not part of the pentad. So the one that we missed out was thrombocytopenia. And I think that's probably, if you remember the pentad, I think you're good for TTP. Fab. So, SBA 5, 7-year-old boy attends ED with his mum due to bloody diarrhea and vomiting. On assessment, he looks pale and is lethargic. You decide to do some blood tests. These show that he's significantly anemic and has an AKI. Which of the following diagnoses are most likely? Let me just open the poll for you. Okay, should be open now. So DIC, HUS, TTP, G6PD, or HELP syndrome. Right, I'll give you 5 more seconds. Fab. So we had a bit of a split, but the answer is B, HUS, which we'll chat about now. So HUS stands for Hemolytic uremic syndrome, and it is one that most cases occur in children. So it's about 90% of cases occur in children, and it's most commonly associated with diarrhea, and especially with this toxin producing E. coli strain 0157. I wouldn't worry about memorizing the exact strain, but it's usually associated with his E. coli diarrhea, which is what causes the bloody diarrhea. And it has a triad, so not like TTP, which has the pentad. This one has a triad. So they get MAHA on the blood film, so you can see those schistocytes. They get thrombocytopenia, and they get an AKI. And it's quite severe. In about half the cases, the AKI requires dialysis, and the anemia as well is like significant enough that you can notice that they're pale. So I don't know the exact numbers that the anemia causes, but it's significant enough for them to be symptomatic with their anemia. So it's quite a nasty one. Next, so DIC is one that I think you probably have all heard of. You might not have associated with it being a MAHA, but it's one that you'll know about. I've attached a video because I think this video explains it probably better than I could. It's an osmosis video, and they're great if you haven't used osmosis videos before. I'd highly recommend. But simply, DIC is this kind of weird condition caused by usually sepsis, but also caused by malignancy. Sometimes some obstetric complications can cause it. And you get this weird thing where you get clotting and bleeding occurring at the same time. So you get loads of clots in your vessels, which leads to organ ischemia and organ damage. But at the same time, because you're forming all these clots, your platelets and your clotting factors get used up, and that causes the patient to bleed as well, and they can get this nasty rash like in the picture. There's no specific treatment for DIC. The treatment is just to treat the underlying cause. So if they're septic, treat their sepsis. And yeah, that's about all you need to know. And last of the MAHAs that you need to know is HELP syndrome. So that stands for hemolysis, elevated liver enzymes, and low platelets. So it's quite nice that it tells you what to look out for in the name. It's a serious complication in pregnancy, usually occurs in the second half of gestation, and it's considered to be a really severe form of preeclampsia. So the symptoms you'll get are hypertension, protein in the urine, and most cases, so it's kind of 50-ish% of cases, they'll come in with right epigastric or right upper quadrant pain. They'll be nauseous, feel just generally unwell, and have a headache as well. The only treatment for it is to deliver the baby, but sometimes the symptoms can continue postpartum, so even after having the baby. And I think in very rare cases you can actually develop it after having the baby. But yeah, so that's HELP. It very nicely tells you what to look out for in the name. And then the last kind of one to be aware of in this section is valve hemolysis. It's caused by turbulent flow through the new valve. If the question mentions a mechanical heart valve, then it could be this, but I think it's probably not that important for exams, but just to be aware of for completeness. So we've gone through a lot of them now, actually. We're being quite quick today, so we're probably going to finish early, which is good. But now we're going to move on to kind of immune causes, immune acquired causes. And we're going to first take a look at the autoimmune causes of hemolysis. So all of this section are ones that I think would be very mean to test you on in exams. They're all very rare, and I think it's unlikely, so I'm going to kind of whiz through them quickly. So yeah, be aware, but I honestly wouldn't worry about them at all. So first is warm autoimmune hemolysis, and that is when you get antibodies reacting against the red blood cells at high temperatures, so temperatures above 37 degrees. And these antibodies coat the surface of the red blood cells, cause them to clump together and then be destroyed. It's usually caused by IgG antibodies, and it's DAT positive. So DAT stands for direct antithrombin, and it's kind of a test you can do to see if the hemolysis is caused by an autoimmune cause, basically. And warm AIHA can be idiopathic, or it can be associated with infections like HIV and EBV, or inflammatory disorders like SLE or rheumatoid, or malignancies. So CLL is the one it's most closely associated with, but also non-Hodgkin's lymphoma. Then we have the cold AIHAs, and these are usually IgM. The antibodies act strongly at 4 degrees C, so instead of 37 in the warm type, act strongly at lower temperatures. Again, it's DAT positive. First type is called cold hemagglutinin disease, or CHAD, which is when the red cells get coated and clump together at 4 degrees C. That's associated with Raynaud's or underlying lymphoproliferative disorders, can be triggered by Mycoplasma pneumonia and EBV. And the second one is paroxysmal cold hemoglobinuria, where you get these biphasic antibodies called Donner-Landsteiner antibodies, which bind the red blood cells at 4 degrees, but don't cause any problems at 4 degrees. It's only when the cells warm back up. So when they're back up at 37 degrees, that's when you get this complement-mediated lysis of the cells. That one's triggered by viral infections, and in questions, I haven't really seen many questions, but it's associated with often a child who's playing outside in the cold and then comes back into a warm house and starts feeling unwell. And last one in this bit is drug-induced autoimmune hemolytic anemias. So these are really rare, but are associated with some quite common drugs. So can be associated with cephalosporins, nitrofurantoin, NSAIDs, penicillins, and levodopa as well as some of the common ones, but it's very rare. Wouldn't worry about it. So that is most of our tree done. So we've only got to do the last little bit now, which are the alloimmune antibody-mediated attacks on red blood cells, of which there are only 2 really. So first one is hemolytic disease of the fetus in the newborn, or HDFN for short. Rhesus disease is the most common form, although you can get ABO incompatibility as well, but it's usually kind of thought of to be to do with rhesus disease. It occurs when the fetus has rhesus antibodies, so is rhesus positive, the mother is rhesus negative, and it's usually during childbirth that a small amount of the baby's blood leaks into the maternal circulation, and the mother's immune system creates antibodies, and then some of these antibodies then go back into the fetal circulation and cause hemolysis. The antibodies only stay in the circulation for a few months, so it's a condition that just resolves with time. Babies often born jaundiced, so might need phototherapy, which is what this picture is of here, for anyone who hasn't seen it before. And the baby can be given folic acid as well to try and help increase red blood cell production, but it's usually just with time it resolves. So now we're going to go on to transfusion reactions. They're not all hemolytic, but I've kind of slotted them into this lecture just because I thought it fit in quite nicely. But yeah, not all transfusion reactions are hemolytic anemias. So next, SBA. You're on call and have just been bleeped by the nurses to come and see a lady on the acute medical unit. She had just started having a blood transfusion when she started complaining of chills, abdominal and chest pain and dizziness. Her blood pressure has fallen from 120/80 to 85/60, and her temperature has risen to 38.2. She does not have any obvious rashes or wheeze. Which one of the following management options would be most suitable for this patient? So is it A, temporarily stop the transfusion and give some paracetamol? B, give some IM adrenaline immediately and stop the transfusion? C, stop the transfusion immediately, start IV fluids and inform the lab? D, temporarily stop the transfusion and give an antihistamine? Or E, continue the transfusion but monitor her observations more closely? We'll give you maybe 5 more seconds. We'll shut the poll there. So answer was C, so stop the transfusion immediately, start IV fluids and inform the lab. Does anyone know what transfusion reaction this one's referring to? Feel free to either unmute or type in the chat. We'll go through them all. There's one SBA and then we're going to go through them all, but just if anyone knows. Trago. I don't know what Trago stands for. Let me look it up quickly, unless it's a different name to one of the other ones. So I'll look up what Trago means in a minute. Maybe it's another word for the same thing. But I was getting at ABO incompatibility. So this is when someone's been given the wrong blood group. We'll go through Taco and Charlie in a bit as well. So clues to why this is ABO incompatibility. So it's happened quite quickly. She's got chills, abdominal and chest pain, and is feeling dizzy. Her blood pressure's dropped, and she's febrile as well. But there's no obvious kind of respiratory symptoms. So that's why it's this one, but we'll talk a bit more about it in a bit. So next SBA is open poll. So you're called to see a patient as they've become unwell an hour after their blood transfusion. The nurses report that their blood pressure is 160 over 110. They are tachycardic at 120 beats per minute, tachypnic with a respirate of 25, and have oxygen sats of 88% on room air. They have a background of heart failure. Which of the following transfusion reactions do you suspect? So A, Charlie, B, anaphylaxis, C, taco, D, ABO incompatibility, or E, febrile non-hemolytic transfusion reaction. Fab. All right. So answer was TACO. So stands for transfusion associated circulatory overload. So usually they're going to have a high blood pressure. They're going to be tachycardic. They're going to be struggling to breathe, so they get overload in the lungs as well. So they get pulmonary edema, which is going to mean they're going to be breathing quickly, and their sats are possibly going to drop. And a clue as well in this one is that they have a background of heart failure. So usually patients who have a TACO type reaction will have a background of some kind of heart problem, usually left-sided heart failure, something that's going to make them more prone to overload. So this is the table of the kind of transfusion reactions that I think are the important ones to know for finals. So you've got your ABO incompatibility, which was what the first question was related to. And then we've kind of gone through that one already. So if anyone has any questions, feel free to ask. But most, very importantly in that one as well, is to tell the lab, because that shouldn't be happening. You know, we do all the tests in this country, so something's probably gone wrong along the way. Charlie and TACO are quite tricky to distinguish between because the symptoms are very similar. They both occur within 6 hours of transfusion. Probably key in the question stem will be to do with their cardiovascular risk factors, and kind of management for them is quite similar. In Charlie, you don't have the signs of kind of circulatory overload other places, so I guess they wouldn't have like edema in their ankles, sacral edema, so wouldn't look overloaded in other ways, whereas TACO they would, is another slight clue, but they're tricky to distinguish between. In TACO you can consider giving diuretics, so you do the basic things, give them oxygen if they need it, try and sit them upright because that will help with their breathing, and consider diuretics if they need. And then the febrile non-hemolytic transfusion reaction. So that's when in your donor blood, when it's been stored, these cytokines have accumulated, and then when you give the transfusion, the body has a reaction to them. And that will occur either kind of during the transfusion or within 4 hours of the transfusion. And it's not serious, it's fairly common, and it's just an isolated fever. So they won't feel unwell, but they'll just get a bit of a fever. And you can just temporarily stop the transfusion, give them some paracetamol, and then carry on. Anaphylaxis, obviously way more severe. So it's a severe allergic reaction, usually to the protein components within the blood. And they'll have kind of the classic anaphylaxis signs, so rash, angioedema, so tongue will be swelling, lips will be swollen, be really short of breath, feel really unwell, vomiting, be hypertensive, feel really dizzy. And that one, you need to stop the transfusion immediately, give them adrenaline, high flow oxygen, steroids, all the other things you do for an anaphylaxis. So they're all the transfusion reactions I think are important for finals. There are a few more. And that is our whole hemolytic anemia tree completed. So that's everything I was going to talk about today. Thank you very much for listening. Please fill in the feedback for me so I know what I can do better next time. And if you have any questions, feel free to ask. The feedback will stay open as well with the video. So if you're watching on YouTube, please do fill it in anyway. It's really just helpful for us to have feedback on what you found useful and what you didn't. But yeah, thank you all for coming.